I think it's a great study, and certainly has been practice changing for me. I don't think the quality police has caught on to it yet, but I think it'll probably catch up. And I think our guidelines will change as well, because this is a randomized clinical trial.
Yeah, that's right. So far, it's the only one of its kind. And so it may not lead to a revolution in guidelines, but it can certainly guide people's practice. And certainly I would encourage people to try and individualize care.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to season finale of Parallax. This is season 6, and we are here for the finale episode again. I think this time last year we were recording in person in London. So that has changed. What has not changed is our guest, who's Dr. Nijjer, who, I think at this point is our guest for the finale episode every year. And, I can't thank him enough for doing this for us every year. So with that introduction and without much further ado, Sukh, welcome back on Parallax, and thank you so much for doing this for us. I really look forward to our season finale episodes.
Thank you, Ankur. Thank you for the very kind invitation and an opportunity to join you and the audience for your season finale. Parallax is clearly a fantastic podcast. It's done incredibly well, and I enjoy listening to it, and I hope the audience gain some value from some of our discussions. I know it was great fun being in person, but this year we're over audio, and so it's nice to be able to speak to you nonetheless.
Yeah, no, likewise. And, I think from what I've heard from, several of your colleagues across the pond and, my colleagues here, is that they really enjoy the potpourri of trials you put together. And I think it's sort of a good wrap up for the year for them, for cardiologists. So I know you've got an excellent lineup for us, and I really liked how you sort of organized them into coronary, structural, and drugs. So I'm gonna give the stage to you, and we can start discussing them one after the other.
Well, that's great. Thank you, Ankur. So I should declare up front that I'm an interventional cardiologist. So my bias will always be predominantly on studies that are interventional. And in this year, I haven't done a lot of studies in the EP space. So for EP colleagues, please do forgive me for my selection. And that's not to say that your studies are not interesting. They are very interesting indeed. But I'm not an expert in that domain. So it's harder for me to speak about those. And so I've thought we can, rather than going through them chronologically in the year, I thought we should discuss them in themes. And I lumped together the kind of concept of coronary and ischemia and studies related to myocardial infarction together. And I thought we would start with that space because I'm in that field predominantly. And so I thought I would mention first off a couple of things that would interest our listeners, and include something like the REDUCE AMI study that was presented earlier in the year at ACC, so circa around March, April time. And I thought this was a very interesting question. They wanted to know whether patients who've had a myocardial infarction that have preserved left ventricular function after their infarct, whether they still do need to have a beta blocker. And the beta blockers in question that were tested were the beta blockers that you would use in your normal clinical practice. So in the United States, often use metoprolol. Here in the UK and in parts of Europe, we tend to use bisoprolol. And they took patients that had had a recent MI, had been revascularized, and had good preserved LV function, and randomized them to giving them a beta blocker versus not. And they took it was predominantly across Western nations, in advanced nations rather than developing nations. And almost all the patients had good LV function. And the vast majority of them had some form of STEMI or NSTEMI rather than an acute coronary syndrome. And what we found was a little bit surprising, given our clinical practice, was when you took patients out for a primary endpoint out to a year, there was no major difference in the patients who had given a beta blocker versus those who were given a beta blocker. And this was in a sizable cohort, so around 5,000 patients were included. They were followed up over the course of around 3.5 years, and they were looking at major adverse cardiac events, and in particular, death and non-fatal MI, and these are the principal risk factors, but also for heart failure hospitalization. And what was surprising was that the event rate was actually very low, and there was no difference between the two arms. And so that does alter a little bit what we do in terms of giving routine beta blockers to all comers, and perhaps we can be a little bit more selective. There are some nuances because there is crossover in both sets of the study. There are, in the beta blocker arm, only around 90% of people were actually getting the beta blocker. And in the non-beta blocker arm, around 10 to 12% of people did actually get a beta blocker. So there is a crossover, but even allowing for that, with an intention to treat analysis, the outcome was that there was no additional benefit. So I thought this was quite striking because we give so many patients beta blockers and they often come back feeling tired and fatigued, and they may have cold peripheries and feel a little bit out of sorts. And there are a number of other side effects that can occur. And so perhaps we don't need to be using them as liberally as we have been.
Yes, I thought that it was a neat study. There were papers published before this particular study. I think they sort of became the foundation for a trial like this to be conducted, which were meta-analyses. I think Shripal Bangalore published one in JAMA Internal Medicine with Deepak Bhatt several years ago, which, I would often cite because, it is a quality metric to prescribe beta blockers post-MI, which all the data from hospitals who participate in NCDR in the US have to submit. So the quality police at our hospitals would be behind us if, we were to not prescribe a beta blocker following STEMI. And, I think you sort of have to document. I mean, it's a clinical decision at the end of the day, and you have to document why it wasn't prescribed. I mean, some patients, like you mentioned, have, low heart rates to begin with. Some don't tolerate the drug at all, have severe fatigue, particularly the young ones. So I think for me, this study, and, I think STEMI care, and you would know this, and probably would resonate, the STEMI care is advanced so much in that, our door to balloon times are shrinking, and, we are right on the STEMI patients and they get revascularized immediately, that if they have a single culprit and not a lot of comorbidities, more often than not, their EFs remain normal. I mean, there have been occasions where some don't even have a Walmarsh abnormality. After this was published, I started not prescribing them a beta blocker and, explicitly documenting why I'm not prescribing and, citing the study, which I do in my notes. So I think it's a great study, and it certainly has been practice changing for me. I don't think the quality police has caught on to it yet, or even NCDR, because I think it's beta blocker is still required, for sort of like as a submission category. But I think it'll probably catch up, and I think our guidelines will change as well because this is a randomized clinical trial.
Yeah, that's right. So far, it's the only one of its kind. And so it may not lead to a revolution in guidelines, but it can certainly guide people's practice. And certainly I would encourage people to try and individualize care. And I think you're absolutely right. When you STEMI patients in the modern era, if they're well revascularized early, and you mentioned some don't even have a wall motion abnormality. We've had patients where we undertake cardiac MRI and there's not even a late GAD pattern that can sometimes be seen 6 months or even a year later. And so, they've really had successful treatment and there's been no scarring. So I think in selected cohort of patients, we can definitely be avoiding excessive beta blocker. And we do have lots of older patients who just simply can't tolerate it with low heart rates, and as well as young patients. Another study that caught my eye was the PREVENT study, which was a study that was performed in South Korea. And it was led by S.J. Park and his team, who are a very prolific team in publishing in the interventional space. And they've always had a very significant focus on the use of fractional flow reserve, which is an invasive pressure wire technology that is used to guide revascularization. And that's been the standard of care around the world for quite a long time. And the PREVENT study really caught people's eyes because it took patients that were FFR negative. That meant a narrowing of the heart artery that angiographically looked significant, but when they performed the pressure wire, the FFR was negative. And then they undertook an IVUS image. And if the IVUS assessment, so that's intravascular ultrasound, suggested there was a significant stenosis, they could be randomized to optimal medical therapy alone or PCI up front, even though the FFR was negative. And this was a modest size study of around 1,600 people. And the vast majority of the patients had stable disease and not acute coronary syndromes. And so perhaps a lower risk cohort of patients. And what they found was made a lot of headlines and made a lot of people say that all of a sudden, we should be stenting all of these people and everyone should be having stents. But I think perhaps was overcalled when people are looking at this and looking at the headlines alone. Because the headlines talk about the MACE rate, including target vessel failure, target vessel myocardial infarction, and all-cause mortality being significantly reduced if you go ahead and perform PCI in this cohort. So FFR negative, angiographically significant, and IVUS significant. And apparently this leads to a mortality benefit. But as always, the devil is in the details. And of course, there is no mortality benefit. And all of the event rates are driven by target vessel revascularization. And in a non-blinded study in which the operators know and the patient knows that they've not had intervention, then that has a significant level of bias. And whilst there was a difference in target vessel revascularization at both 2 years and 7 years, there were no true differences in myocardial infarction or mortality. And so I think some of the early headlines that came out of this were perhaps a little bit drawing too deep a conclusion from what the data actually shows. And there was also a desire to talk about this being an example of us being able to identify vulnerable plaque, but actually the principal risk predictor of whether the lesions were considered significant was simple plaque volume. So the more plaque volume you had, and the smaller the lumen area, the greater the chances would be classified as significant. And in fact, thin cap fibroateroma and other markers of vulnerable plaque, such as NIRS and lipid-rich plaque on NIRS, was actually only a fraction of the patients. We're talking a trivial percentage. And so, in fact, this study perhaps doesn't lead us to the conclusions that the authors proposed or the headlines proposed, but it is interesting. It does suggest that we do have patients that have significant disease that may well not be physiologically significant, but can drive events. Most of those events are non-prognostic, but they do drive healthcare cost in terms of revascularization. I think the thing that we have to consider with this is, do we stent now or do we stent later? And what is the potential cost to the patient? What's interesting is at 2 years, putting a stent in early had a very, very low event rate in the stented arm, but out to 7 years, that was no longer benign. And that target vessel, that target lesion, had its own event rate of around 5%. So, and this is in a very stable cohort of patients with IVUS optimized intervention, suggesting that just putting a stent in does have its own event rate associated with it. So we have to have a little bit of caution. And as interventionalists, I think most of us do have that caution, and we shouldn't get carried away with all of these things. What were your thoughts on that study, Ankur?
Yes, I thought interesting study. Certainly, we see this cohort of patients in our clinical practice. I think I remain on the fence. I mean that for me, the decision is individualized. It really depends on how the lesion is looking angiographically. I think after the study was published, I actually became, not that I don't use intravascular ultrasound. I do in my practice, but I think I became even more liberal in trying to determine what the lesion looks like on intravascular ultrasound, because typically I would use IVUS after I've stented and I want to see what the stent looks like. And so the way I use IVUS is more common post-stenting compared with pre-stenting. I think this study sort of changed my practice to sort of use it pre-stenting in lesions where I'm not convinced whether or not I should stent it. And I would go on and say that it did change my practice a little bit because I've been convinced after what I've seen on IVUS that this lesion has significant high risk features or characteristics, and looking at how the patient presented in terms of clinical scenario, whether it's unstable angina, which I believe is diminishing with our use of high sensitivity troponin, or whether it's non-ST elevation MI. That these lesions, do have high risk features with regard to thin cap fibroatheroma, and when you look at the core, I use virtual histology, so the definition that Mahira published in JACC imaging or JACC interventions, where you're sort of circumferentially looking at the degree of what is red in color in the virtual histology image, and seeing if it's more than 40% in each frame. And then I also look at the arc of the calcium. And that's how I determine if it's a thin cap or a thick cap fibroatheroma. And so go ahead and stent it. So I have done that in my practice after this paper was published. Some colleagues are on the fence, precisely because of the reason you mentioned, that at 7 years, the event rate was not trivial. Sort of you're exchanging one disease with another. So why not just do medical therapy? I think the jury is out there. I think, again, it's individualized. Not really the best time to sort of discuss this with the patient upfront. I know there are, at least in the US, we use sedation, so they are under sedation when moderate sedation, so still conscious sedation, but you can't really have these intricate conversations with them whilst they're on the table and you have a lesion like this. So you sort of do what's in the best interest of the patient and what you think is in the best interest of the patient. So I've gone ahead and stented these lesions.
Yeah, I think it's reasonable for you to do so. I think if you've got a significant stenosis and the purpose of putting the patient on the table, and you've got a patient with chest pain or an evidence of ischemia, and then you have a high volume plaque with high risk features, the patient is expecting you to put a stent in. But discussing these things with patients is really, really quite challenging. And I've listened into some conversations with physicians or cardiologists who are having these discussions with patients, and everyone brings their own level of bias to it. And for people to say that they don't have the bias, whether you have a medical therapy bias or a surgical bias or a stenting bias, there is inevitably a bias. And patients will often look at you and say, "Well, why are you asking me? You're the expert, or you're the doctor. Please guide me in making decisions." And the reality is, a lot of these studies don't give us a clear answer, and they open a can of worms. They give us more questions and don't help answer it for the individual patient. Remember, no study can answer it for one individual patient because there's so many different variables that are involved. And so you do have to combine that. And that is what evidence-based medicine is. It's taking your local guidelines, taking your clinical experience and expertise, taking the data from a randomized control study or meta-analysis, and then combining that with patient wishes. And I think what a lot of people have converted evidence-based medicine into is, I'm just going to do what the last study said, or what they said on the podium at a big conference, or purely what's on the guideline. And the reality is that true evidence-based medicine is bringing together all those different components and then guiding your therapy for the individual patient. And if you have to stop the case and have a discussion with the patient, then by all means, in a stable case, you certainly got the option to do that. One other study that I thought was interesting was the FAVOR-3 study with its European component of the study. This is the use of the calculated fractional flow reserve technology. So listeners will be aware that there are a number of technologies that allow you to compute a fractional flow reserve based on how the angiogram looks. And I've always thought that this was slightly farcical. My background in training is predominantly in coronary physiology. It's what I've done my PhD and published research in. And I remember that physiology was designed to get around the limitations of angiography. And that was angiography was validated against non-invasive stress tests like treadmill tests, which we know are highly inaccurate. And now we're going full circle and we're looking at the angiogram and asking a computer to compute or impute some data based on a couple of frames of an angiogram and tell us what the fractional flow reserve is. And so it's a slightly weird situation, but this is what we've found ourselves in and what the companies are kind of pushing us to do and what some operators are keen to do because they find the pressure-wise fiddly, tiresome, expensive, particularly if you're using adenosine, additional cost and discomfort. And so QFR is one of those technologies out there which allows you to compute an FFR. And so far, much of the published data, particularly coming from the Far East, has been very favorable for QFR. But this study that was performed in European centers just puts the brakes a little on our thought process on this. And prior studies have demonstrated that these non-invasive predictors predict FFR really well. But these are clinical outcome studies. And in the FAVOR 3 study, there was adverse signals seen in the QFR arm. And in fact, the event rate was much higher. Not so much that it would instantly cause the study to be stopped, but a true difference in the arms with a primary outcome in patients having intervention of almost 7% versus an FFR group having an event rate of around 4%. So a meaningful difference. And much of this was driven by myocardial infarction. So this is a relatively hard endpoint, not death, not unblinded revascularization decisions, but myocardial infarction. So something that we can have objective biomarkers on. And there was a higher event rate in the QFR arm. And when you look at the data, it's because there were higher rates of stenting in the QFR arm. And we know because if you ask a computer to compute an FFR, it doesn't truly understand the viability of a downstream tissue. It doesn't truly understand the amount of myocardium that's subtended. It's essentially performing Navier-Stokes equations on a relatively crude outline of a tube. And so you will overpredict your FFR. You will make things look more positive than they actually are on any of the platforms. And I think this will apply similarly to some of the other platforms like CathWorks and some of the other technologies out there. Now, they've still got studies coming, and it'll be interesting to see what those studies show. But I think it should just give those operators who use these computed technologies just a slight pause before they rush to put a stent in and think, the technology is suggesting that this vessel is positive. Do I really need to put one in? Should I be using a pressure wire to measure it fully? And it's just an interesting little caveat whenever we do these studies that have all been very helpful and positive for several years, then all of a sudden we get this negative outcome worth reflecting on. Do you have much experience of using these technologies, Ankur?
Well, so the answer is no. I've not used QFR, even though I've published one paper with Javier Escanad trying to recruit for the study. What are your thoughts on use? I mean, have you used it routinely? Are you using it routinely, or is it?
Yeah, we have CathWorks in our particular lab, and the technologies, when you look at them, are very attractive, and you can see why people would be enamored with them. The workstations look quite beautiful. They produce these beautiful pictures. They're great for showing patients, show this generated image, which has color flow and all these kind of things on it. Whether they truly save time, I'm less clear on. And that might be because our particular center, we do a very high volume of pressure wire during diagnostic angiography. And so we are very versed at being able to get the wire ready and down a particular vessel. And so I've not found that using a computational system much quicker, to be honest. And because we are in the process, we're doing a couple of the studies, I found that the outcomes are not as good as the published data so far. And so, my mind is not made up. I'm certainly not closing the door on it, but I'm slightly cautious in my interpretation of the results.
Why do you think, I think you sort of mentioned this briefly when you were discussing the trial. What is lead, and you mentioned that there's more stenting, and that's why the outcomes are a little different when it comes to events downstream. Do you think there's overestimation of significance?
Essentially, yes. So those of people who've been in the cath lab and done a pressure eye will know that if you have a lesion in a circumflex or the right coronary artery, the pressure eye can often be negative, even if it looks quite significant, because of some hydrostatic forces that exist in the catheter, the aorta, the orientation of the catheter in relation to the vessel. So all of these things push towards a negative value. Now, these systems, like UFR or Catholics, don't do that. They're purely drawing an outline of the coronary vessel, and then they're computing it using Navier-Stokes equation. And part of the process of doing that is assuming a very high flow rate, but that is slightly nonsensical, because if you have a flow-limiting lesion, you cannot have a high flow rate. And so by definition, the technology is asking for something that cannot physiologically happen. And therefore, you will over-predict the significance of a given lesion. And if you've got a sequence of lesions, it becomes, I suspect it becomes more inaccurate. I don't say that statement strongly. I think it's just a clinical suspicion of mine. And so I think that's one of the reasons we over-predict. It may also, another factor that may drive events, and this is again a clinical suspicion, is when things become too easy, then people make mistakes. And when we make things, we want them to be easy, but not too easy, because it makes operators a little bit slack. And so if you're doing something that is where the computer's just telling you what to do, you go, oh yeah, okay, that's positive. Quick wire, quick stent, bang, done, I'm out. Isn't that fantastic? And you aren't taking the time to interrogate the vessel with upfront IVUS, knowing what needs modifying with catheter modification, making sure the stent is well expanded afterwards, making sure there's no dissection. I think you do have that risk of just a few patients going in the wrong way and making your outcome of your study negative. And so it's quite important when we're doing these studies that we don't kill these nascent technologies by just being a bit slapdash. And I think that does happen. That genuinely does happen in lots of these trials.
Yeah, no, excellent point there. Yes, so, I don't know if it's prime time yet for me, at least, or, quite frankly, to be honest with you, for a lot of operators in the US. But I think I'm going to keep watching the space to see what's in the future.
Yep. So let's talk just a slight left turn here. I'm going to mention a study that actually I was part of, and so I'll declare a bias here. I'm on a part of the study design team and helped recruit into it and contributed to the paper. And that's the ORBITA-COSMIC study that was presented by Michael Foley at ACC earlier this year and led by Rasha Alami, who's a colleague and friend. And this was in a technology that we really didn't understand or really believe in. And this was the coronary sinus occlusion devices, which is used for people with intractable angina. And the study that Rasha and Michael designed was to really challenge the coronary sinus reducer device using a placebo-controlled sham-controlled study. So they took patients who have intractable angina and that had had complete revascularization, and no other revascularization options remained. And they were quite rigorous in how this was done. The cases were reviewed in multidisciplinary teams across multiple hospitals with CTO operators involved to say whether there was any other option available for the patient. And if there were no other options, they then had a cardiac MRI to confirm that they had ischemia, and they had to have demonstrable ischemia on a stress diffusion MRI. And they were then randomized to a sham procedure or having a coronary sinus reducer device implanted. And all the patients underwent a procedure that had vascular access through the neck, large bore access, They underwent a procedure that was identical in terms of length. The patient was blinded using a combination of sedation, obscuring their vision and obscuring their hearing. And then they either had just some measurements made within their right ventricle and into the atrium, or they actually had a coronary sinus device implanted. And they were then tracked over time, and they reported their symptoms using an angina reporting app, which was developed by the ORBITA team. And what we found, and we were surprised by, because we were a little bit unbelievers of this particular technology, was that the patients did have a significant reduction in angina. And it took a little while, because I think the way that this technology works is it takes a while for this device. This is basically a stenosis being implanted within the coronary sinus. It takes a while for it to be endothelialized, and that then has some kind of effect on the body, that it reduces angina. And there was a significant reduction in angina. And after around 3 months, we saw a meaningful reduction in angina that was then sustained out to 6 months. And this is in a blinded, sham-controlled manner. What we didn't see was a mechanistic explanation of how this was working. So the team did lots of different tests. They did lots of stress MRIs and measured blood flow using quantified stress perfusion. And there wasn't a meaningful change in that. But there were patients having a meaningful improvement in their symptoms. And so this is now a technology that we use in our hospital, and we have a process of being able to refer patients for this who've got intractable angina. And we do find patients have benefit in this over time. And so this is another tool for us, for those patients that we are struggling with, or are already on maximal therapy and don't have any other revascularization strategies. Is this something that you've used before, Ankur, or seen in practice?
I have not used this device before. I have a really good friend and colleague, Rishi Puri, at the Cleveland Clinic, who's involved with a similar coronary sinus reducer device, and they published their first patient in your intervention. I believe they're enrolling. So I certainly understand what the concept is and what the mechanism is. Question for you, as you're one of the investigators here, is, well, first of all, congratulations on doing a sham-controlled device trial. I think it's sort of become the flagship of the ORBITA team. How do you do a sham-controlled device trial with a large bore catheter? I think the investigator in me wants to understand the nuances of getting this through, the institutional review board at your organizations and hospitals.
Yeah, I think the having done the ORBITA study helps massively, because we can demonstrate to the ethics boards and the IRBs that there is a need to do sham control studies to demonstrate the utility of these devices upfront, early in the device's lifespan. And so they do give us approval. And it is a credit to Rasha and her team that they can do these in a safe manner without any major events to the patients undergoing the sham procedure. And they have a procedure that is identical. They have the same large bore access placed in their neck, and they do undergo a exposure to fluoroscopy in the cath lab, and they're lying on the table. And as far as they're concerned, they could well have had the device implanted. And they look for the quality of the blinding, and patients are amazingly well blinded. And the way the blinding works is that even our reporting of what we've done in the case is kept blinded. So it's not documented formally in the reports that go out to the patient and the primary care physician. And the staff that looking after the patient on the unit also don't know. And so the blinding has to be done very rigorously in order for these studies to be performed. But amazingly, it can be done. It can be done. And I think the team have clearly got very used to doing it, and our hospital is used to being able to deliver on something like this. And I think this is a huge strength, and it's something that I feel very privileged to be able to work with the ORBITA team and see what they can produce. They're relentless, I can tell you that.
Yes, it's fascinating that you can do a sham-controlled device trial and do it in such a blinded fashion, in such a rigorous manner. So hats off and congratulations to your team. About this device and, certainly about this concept, what do you think is working here, Sukh? I've sort of remained skeptic as well, but some of the papers that I've read, prove me wrong and, suggest otherwise, that this actually is working. What do you think is working here?
I'll be honest, I don't understand. It's not entirely clear to us. So I suppose theoretically, if you're slowing down the transit of blood through the coronary sinus, then you are allowing greater time for a given red blood cell to be passing through the cardiac capillaries and therefore allow for greater oxygen extraction and therefore a reduction in angina and a reduction in ischemia rather, and therefore that could reduce angina. Whether that's really the case, I don't know. Surely if we're choosing transit time, then there is a greater risk of thrombosis. If it really is that as a mechanism, then should we be able to measure a difference in oxygenation in the cells that are in the coronary sinus, which my understanding is that we don't see in clinical practice. And so I don't know is the upshot of it. As part of this, they have made measurements of microvascular function and they've done physiological analysis. And I suspect the team will publish those papers in due course that may shed some further light. But it's not as clear as we would like at present.
And in terms of adjunct pharmacotherapy, are you discharging these patients on, direct oral anticoagulants or dual antiplatelet therapy? Is there a specific duration? Most of these patients, I assume, would certainly be on, management, the chronic coronary syndrome management, which may or may not include DAPT, certainly may include clopidogrel monotherapy with or without rivaroxaban, 2.5 milligrams BID. There are so many combinations of drug therapies for these patients. Particularly after this device, is there a recommendation for either use of anticoagulants or antiplatelets?
Surprisingly, this device is quite tolerant. So all of these patients were on maximal guideline-directed medical therapy for the management of their angina. So they were all on multiple medications, including the drugs that we don't still fully understand, like ranolazine and some of the others that have a benefit. They were all treated with aspirin and clopidogrel. And the clopidogrel was given for 6 months, and it was given equally in the sham and in the device arm.
Perfect. Excellent. Well, let's move on to the next study then.
Yep. So just finishing off in the kind of coronary space and ischemia space is the danger shock study, or DANGER, which is the Danish and German study that looked at the Imperial CP device, which is a microaxial flow pump that is placed through the femoral approach and passes through the aortic valve and essentially sucks blood out of the ventricle at very high speed and dumps it into the aorta. And this is a device that is used in the presence of cardiogenic shock. And to date, we've not had very much success in patients who are in cardiogenic shock in being able to show a demonstrable improvement in outcomes with any of these support devices. And in this study that was published by Holger Thiel and colleagues, they demonstrated a significant improvement in outcomes. And whilst this is incredible work and it's very hard to randomize patients who are in cardiogenic shock, there are some caveats and things just to consider a little bit on it. This study should be applauded, and it does move the space forward, but it's perhaps not the panacea that we will hope for. They took a study of around 355 patients, so a small cohort of patients with ST elevation myocardial infarction and in cardiogenic shock, and they all had to have low blood pressure and evidence of end organ hyperperfusion. So they had lactates measured, and I think the lactate values on average were pretty high. And they all had to have had a near side echocardiogram to show that their ejection fraction was reduced. And they randomized them to standard of care, or to having the Imperial CP device being implanted. And there was, as you would expect, a degree of crossover. And there was a fairly high number of patients in the standard of care arm ending up with a support device, because these are sick patients and you can't deny them that. And many of them did go on to also have ECMO as well. And what we found in this study was that the event rate was very high, and it was very high in all groups, and the outcome was all-cause mortality at 6 months. And what we found was in the Impeller arm, the mortality occurred in 45.8%, and in the standard of care arm, it was 58.5%. So around a 25% risk reduction in death. It's a hard endpoint at 6 months, and so a clear advantage to using the Impeller device. Obviously, the disappointing outcome is that still, despite all of these massive advances, half of the patients who present with STEMI and shock still die at 6 months, which is really quite a profound and sobering number. And what we did still find was that there are a number of complications that occur from having these devices, principally from the fact that they are still large bore, still require heparinization. So the event bleeding rates are very high. So around 20-25% of patients had severe bleeding. Limb ischemia was very high, as we often see, because many of these patients are sick and they have vascular paths. And so vascular injury is high, and around 6% of acute limb ischemia, which is relatively high, and a very high rate of people needing renal replacement therapy. And it's challenging because renal replacement therapy is needed in cardiogenic shock, but there are a number of other potential things that can occur with these devices, and sepsis as well. So these bits of kit are not benign, but I think most of us would agree if we had a loved one or ourselves, we'd had a STEMI and we're in cardiogenic shock, then we'd want to be given the chance to pull through. And it does appear that the Impeller CP device does provide that opportunity for people, and so it's something we should be considering for them going forward. The issue is, how do we pay for it? These devices are not cheap. They're not universally available. In my particular institution, we do have it, but it's available in very small numbers. It's very challenging to have it costed. It's the centres in the UK that use it as part of cardiac transplant programs, and so it's not in routine availability. And these patients often have a very stormy course on intensive care, which also causes an additional cost. So huge number of caveats that come with this, but it is moving the field forward, and there are people who are interested. Well, I have a friend of mine, Tom Keeble, and some of the team here in the UK are looking at these data and thinking, how can we advance care forward? And they're moving forward with a number of other shock studies here in the United Kingdom, and I'm sure they'll be having similar studies like this across the US as well. I imagine that this is something that you guys in the US use quite frequently, Ankur. Is that the case?
Yeah, so it's routinely available to us. It's at our dispense in our cath labs, and I've remained a skeptic for the longest time. Because all the data until this trial were observational, and you and I know how hypothesis generating that is, but it's not truly the evidence. Even though it's hard to recruit for a patient population as challenging as cardiogenic shock patients. And, whatever we've done so far, when we've thrown the kitchen sink at them, and, the mortality has not budged. I mean, it's remained at 50% all these years, despite all the advances that cardiology has made in the last maybe 3 or 4 decades, in acute myocardial infarction. So I think clearly, as you mentioned, it moves the field forward. Now, the device finally has one randomized clinical trial in the space. So it has, but like you also mentioned, and has been my experience with the device, that, upfront, whilst the patient is in the cath lab and you're unloading the ventricle and you then do your PCI, everything goes fairly smoothly. I think the complications start to occur when these patients are in the ICU and they have the device in, and it's been day 2 or day 3. And, you're now dealing with device alarms, and you're dealing with hemolysis, and you're dealing with an ischemic limb. And then these patients are sick to begin with, and then you slowly start seeing that the hemoglobin is trending in the wrong direction, and you're sending hemolysis labs. Then you see that the platelets are dropping, and they're still on heparin, and now they're even more sick. Now there's AKI, now you're getting the nephrologist on board, and now you're starting renal replacement therapy. So you see where I'm getting there with this.
I think it's a highly emotive area. I think it's amazing that they were able to include patients who are really sick in a randomized control study. So that should be applauded. Naturally, there will be a selection bias in that, because in a patient that you think has to have the device, you may not randomize them. And so that will create a bias against the device, actually, because you will then only randomize slightly less sick patients. And as a consequence, and you will drive your study to the null, yet it still shows benefit. I think we're so used to seeing big improvements over the years, and now we've gotten to a point where it's harder and harder to prove a benefit. I would just look at it in a slightly different way as well. I think we do have benefit, and the patients we see are now sicker than they ever were. So if you would go back 15 years, if you go back to the beginning of my kind of cardiology career, so 18, 19 years, these patients would never have even got onto the table, okay, because they were so sick. By the time they came into our hands, then operators would have said, you know what, I'm not even going to put this patient on the table. And now pre-hospital care is so good. And our institution of antiplatelet therapy is immediate. And we have all these adjunctive therapies. We echo these patients immediately. When I started, even having an echo machine in the room at the same time was just not something that was feasible or possible. And so although we say, oh, look, the outcome is still bad, I would say that actually people probably died too easily before. And now we're fixing all of those, say, easier cases, still sick, still super sick, but now we're left with the super challenging cohort of patients. And so it looks like we aren't making any incremental gain, but in fact, we have made incremental gain. We're just not appreciating all the difference that all those other little smaller things have had. It's hard to, so not quite the Hawthorne effect, but that we have a learning effect whenever we're doing a study. And whenever we do any new technology, as the more we use it, the better we get. We understand where it can be used, and our treatment of even patients who are not getting that particular device gets better as well. And so that means there is a drive to the null, which makes it harder and harder to prove that something works. And so, and this applies to everything. And this, it probably explains why MitraClip and all these different things have struggled to be able to show benefit up until recently. Just before we move on into kind of other space, I thought I'd just mention a couple of other kind of coronary type things. So I know that in the US, the recent unlocking of drug-eluting balloons, so drug-coated technologies has been an interesting growth. I think the limiting factor is how these things are being priced in the US. It just seems, to me, it's sitting in the UK, it seems a little crazy, because drug-eluting balloons in the UK are expensive, more than a standard balloon, but not much more. Whereas I think, and as I understand it, the cost in the US is phenomenally high. But what's interesting is that some of the studies of using a drug-coated balloon approach only has not quite been the success that people were hoping for it to be. And the cage-free study, which was one of the big DEB studies, unfortunately was negative, and this was in a de novo lesion setting, so patients with standard coronary disease, de novo lesions, randomizing to a drug-eluting balloon only versus a drug-eluting stent, and the outcome was negative, and they did not meet non-inferiority, which just gives you a little bit of caution. And another study that I think should definitely be mentioned, and again, I'll declare self-interest here. I was contributed to recruitment to it, which was the SENIOR-RITA study led by Vijay Kundanayan from Newcastle here in the UK, and was looking at older patients, those over the age of 75 who had had a non-STEMI and non-ST elevation myocardial infarction, and whether they should be offered routine invasive angiography versus medical therapy alone. And this was also a negative study in the form that there was not an advantage seen by routine invasive procedures. And there was, as one would expect, a higher rate of major bleeding in the invasive group. But no benefit in cardiovascular death, a reduction in myocardial infarction, but not a overall win for invasive coronary procedures in an older cohort of patients. And so that just some people see this as a positive component because some older people, we do feel under pressure to take them to the cardiac catheter lab, and that may not be the right thing for them. It will vary. I think someone over the age of 75 is, the age is a little bit of an arbitrary cut point here. There are people who I know who are in their early 80s who are physically fitter than I am. They're running, lifting weights, and are in really good shape and are not on many medications. Versus another patient who might have quite significant dementia and other cognitive impairment, which comes with its own limitations. They may be physically frail. I don't know what your thoughts on this is of taking older patients to the cath lab, and what your thoughts are for when you're asked to do a 90-year-old, say.
Yes. So I really enjoyed and welcomed the publication that, Vijay led, and, congratulations to you for being a part of the study. I think it's been, again, these decisions were individualized, and, one would try to convince our general cardiology colleagues that, hey, look, there are multiple comorbidities. Is an older patient is frail, why don't we just do medical therapy rather than subjecting them to a procedure and then dealing with the consequences of, acute kidney injury and bleeding. Those are the two big ones for me in this older, more frail cohort. And so I really welcome the paper, and I think it's sort of been practice supportive for me. And then I think now I can sort of go there. I have an evidence base to speak with the patients and their families. I had a patient recently, actually, after this paper was published, where the patient was not too keen. And, I sort of agreed with the patient that this would be too invasive for him. He was 88, had bleeding events, had a AKI, clearly had non-ST elevation MI, and said, hey, look, I just want to see how medicine works. And I would love to see you back in the office, see how I'm doing. If I'm doing fine, I want to be left alone, which is what we ended up doing. And, this paper came to the rescue for both the patient and myself, and well as, trying to convince the general cardiologist. I said, we need to familiarize ourselves with this newer data on how these patients do with conservative therapy compared with invasive therapy. And this is an important publication in the field. So congratulations to the team. Really enjoyed it.
I think it's an important paper. The trying to apply it to individual patients is always the challenging component. And this is where, my commentary about applying evidence-based medicine, and it sounds like you did exactly that for that particular patient. And it does vary a lot, doesn't it? And practice does vary a lot between individual places. One of the things that I found was challenging where I work was patients would come through an emergency department and our acute medical service, and they may be seen by a non-cardiologist really quite early up front. And they were told, hey, it looks like you're having a heart attack, or you're having a non-ST elevation heart attack. You're going to have an angiogram. And then, so when we would then see the patient and then say, look, we're the cardiologist, and we'd like to include you in this study, that you may get randomized to not having an angiogram. And they'd be like, their immediate response was, no, the other guy said I was going to have an angiogram, so I'd like to have an angiogram, please. And so we actually struggled a little bit to recruit patients because of that expectation. And that may be a unique thing to where I worked, because particularly where I worked, there lots of people are really quite fit into their older age. And yet there are others who are really quite frail and would say exactly the opposite and say, there's no way I'm having an invasive procedure. And we do get asked by non-interventional people perhaps in the general cardiology service to say, hey, please do an angiogram on this patient. I'm really worried. Their troponin is elevated, really quite high, or they've got ischemic changes on their ECG. And I think those of us who end up having to do the procedure, we know that the vessels tend to be highly tortuous. They tend to be heavily calcified. It's very tricky to get anything down their coronary vessels. We're going to end up needing rote ablation or calcium modification with shockwave or other technologies, which adds a degree of risk and complexity. And so I think those of us who end up having to do that kind of work know that actually sometimes less is more, and trying to manage the patient medically, if you can get away with it, then that might be better for the individual patient. Now, just I know I said I was going to move on from coronary. I just wanted to mention one extra thing. I'd just be interested in your take on this, Ankur, because I know you're a TAVR operator. And whilst I did TAVI while I was training, it's not something I do as my routine practice. Is the Notion 3 study that was shown at the ESC in the summer. Notion 3 was looking at patients that are undergoing a TAVI procedure, so severe aortic stenosis, and not felt to be a surgical candidate, and they're going for a TAVI. And we know that half of these patients, or slightly more than half, have coronary disease. And in many cases, it can be really quite severe. And the learning to date has been to treat the valve, because the valve is often the most critical lesion and is driving the patient's symptoms and will drive patient's outcome. But what I've come across as a clinician and as an interventional cardiologist is that patients do really well after TAVI. They then represent with their coronary disease, and they present with either angina or they present with STEMI. And STEMI are after in particular, if you've got a self-expanding valve like a core valve that's in the way and is occluding the coronary origins, suddenly becomes very tricky to treat in a STEMI situation, because catheters and guiding catheters don't sit very well through a TAVI valve in some circumstances, particularly when you add in the tortuosity and the complexity of an older patient. And so my feeling was that, should we be treating those coronaries at the time of their TAVI valve? And certainly that's what we used to do when TAVI first started, and that was the concern. And you're going to rapid pace these patients. Are they going to decompensate? And so we used to revasc before putting a TAVI in. And now the practice has evolved the other way. And Notion 3 suggests that maybe we should consider revascularization again. And I like this study, and I'm showing my bias here. I like it because this is my priors suggest that this is what we should be doing. And they took patients that had severe coronary disease, at least something that was positive on a pressure wire, or something that was more than 90% in a large enough vessel that needs a stent, and they randomized them to doing just a TAVI or having PCI at the time of the TAVI or shortly before, shortly after. And they found there was a really big difference. There was a 10% difference between the arms here. So in the PCI group arm, they had a 15% event rate of all-cause mortality, myocardial infarction, or urgent revasc, and 25% in the conservative therapy arm. So those patients that just had the TAVI valve and had their coronaries left had a 25% event rate out to a year. What's your thoughts on that, Ankur? Do you prefer to revasc these patients, or do you leave them for medical therapy?
Yes, so it's an interesting question. It's a question where which I've looked and published as well. We did a paper. I think Rishi led this. He's the senior author on the paper. This was published, I think, around the same time that Notion 3 came out, maybe a little earlier, in the European Heart Journal. Observational study. We actually showed that. And we also stratified based on the severity of coronary disease and showed that revascularization does not make a difference in the overall outcome. We followed these patients out to 2 years. This is about 2,000 patients, all comers at the Cleveland Clinic, my former institution. And then out came Notion 3, which showed that there is a difference. So this is what I do in my practice. I think if and this mostly I think is driven by the fact, which you also mentioned, that these patients do have coronary events downstream following TAVI, and reaccess becomes a problem, particularly if it's a self-expanding valve, which is not uncommon in my practice as a TAVI operator. So what I do is if there is a proximal lesion which is obtaining a significant portion of the myocardium, then I will go ahead and revascularize upfront before TAVI. And then we would offer these patients TAVI. I think it's now, looking at the data and the evidence, in totality, and also looking at how these patients present following TAVI with acute coronary syndromes, I think is a reasonable strategy. Is looking at the degree of myocardium subtended and the extent of myocardium subtended, and if it's a proximal stenosis, whether it's mostly the RC or the LAD, we tend to go after them up front and then offer them a valve. And I think, patients are always looking to you to make the right decision. If it's a distal lesion, if it's a distal LAD, if distal RCA, tend to leave it alone. Because I don't think that's gonna make much of a difference. But that's how I practice. And what are your thoughts on the strategy?
I think that's what I would agree with. I think if you've got a proximal lesion, particularly in a major part of the epicardial vessels, the distal vessels, really don't worry about them. Left main, proximal LAD, and the RCA, I think those areas definitely, and that's where the plaque tends to occur in these patients with aortic stenosis, and it can be tricky because they're going to need rotablation. A lot of them, they're going to be heavily calcified vessels. And it can be tricky because they can become unstable. They've got an aortic valve that's significantly narrowed. They may have pump that is beginning to deteriorate. So these are not straightforward patients. And that's why I think we need to work in a multidisciplinary team way. And I think if we've got an evolving group of people coming through the system now who are purely TAVI operators, they do the valve and they don't do anything else. And so they will be very single-minded on doing that, and they should work alongside coronary operators who are well versed in being able to do the complex bits of coronary, and so they could work together to be able to get this done. And I would suggest if you can do it in a staged manner, very safe for the patient. Remember, these are often older, frailer patients. I think that would be a sensible way going forward.
Yes, exactly. I mean, to just finish the discussion on how to manage coronary disease in the setting of aortic stenosis, I actually have a patient. We're going to schedule this case. Severe aortic stenosis. There's 3 vessel disease. I think at least the LAD and the RCA need to be done. He's got ischemic cardiomyopathy, and so the plan is to do a BAV, put an Impella in, because it's going to require atherectomy. The LAD will, and then sort of see how the patient does, and then stage the patient for a TAVI. So, to your point that it needs to be done in a staged fashion, I think this case is illustrative and demonstrative that these patients do exist, and I think planning upfront and doing them in a staged fashion is the way to go.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app, or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.